Hello, Miss Michelle.
Hello, doctor. I have difficulty in eating and even burping. My chest also hurts.
Probably you have achalasia.
What's that, doctor?
What is achalasia? It is triad of 1. Incomplete lower esophageal relaxation, 2. Increased lower esophageal sphincter tone, 3. Peristalsis of esophagus. Primary achalasia is due to degeneration of nitric oxide producing neurons that cause relaxation of lower esophageal sphincter, degenerative changes of extraesophageal vagus nerve or dorsal motor nucleus of vagus. Causes of secondary achalasia are 1. Trypanosoma cruzi causes destruction of myenteric plexus leading to aperistalsis, 2. Diabetic autonomic neuropathy, 3. Infiltrative disorders like malignancy, sarcoidosis, amyloidosis. 4. Polio causes lesion of dorsal motor nucleus, 5. Algrove syndrome. AAA syndrome including achalasia, alachromia, ACTH, resistant adrenal insufficiency. 6. Immune-mediated destruction of inhibitory esophageal neurons, for example in HSV-1, Sjogren syndrome, autoimmune thyroiditis. Treatment options include number 1. Laparoscopic myotomy, number 2. Pneumatic balloon dilation, number 3. Botulinum neurotoxin injection. Hello, miss.
Hello, doctor.
How are you feeling?
Doctor, I feel heartburn and a sour-tasting fluid regurgitates in my mouth. It happens mostly after taking food.
We will give you proton pump inhibitors. It will improve your condition. If your condition is not improved, we will perform endoscopy. Whenever patient comes with before-mentioned symptoms, he may have GERD, Barret esophagus, or adenocarcinoma. These 3 have similar clinical features, so we discuss these 3 together. Reflux, esophagitis/GERD. Pathogenesis of GERD is that when lower sphincter of esophagus relaxes, then gastric content moves upward. Now let's discuss causes of GERD, which are stomach-related factors include gastric distension, delayed gastric emptying, increased volume. Then food-related factors include alcohol, tobacco, CNS depressants, and some others such as pregnancy and obesity. Morphology can be studied as of mild GERD and significant GERD. In mild GERD, simple redness is seen endoscopically. For significant GERD, we can visualize erosions endoscopically and histologically. Eosinophils as well as basal zone hyperplasia are seen. Along with this, elongation of lamina propria papillae are also evident. Now let's discuss Barrett's esophagus. Let's explain what is Barrett's esophagus. Normal squamous epithelium of stomach is replaced by intestinal epithelium, that is columnar epithelium with goblet cells. It is associated with increased risk of gastric adenocarcinoma. Now let's discuss morphology of Barrett's esophagus. First, look at gastroesophageal junction. There are tongues of red velvety mucosa extending upwards from the junction. This red velvety mucosa alternates with normal pale mucosa, and distally brown-colored gastric columnar mucosa is seen. Microscopically, we can see change of epithelium from squamous to columnar with goblet cells. Goblet cells are diagnostic. We can also visualize dysplasia, which means abnormal number of cells. Dysplasia can be low-grade or high-grade. Features of dysplasia are atypical mitosis, nuclear hyperchromasia, increased nucleus to cytoplasm ratio, etc. High-grade dysplasia invade mucosa and become intramucosal carcinoma. Treatment for low-grade dysplasia is controversial, but main focus of clinician is to treat high-grade dysplasia and intramucosal carcinoma, and these methods are used. Now let's discuss esophageal adenocarcinoma. Pathogenesis of esophageal adenocarcinoma is mutation of tumor suppressor genes like TP53 and CDKN2A and amplification of oncogenes like EGFR and CDKN2A. Grossly, we can visualize that it occurs in distal third of esophagus. It initially appears as flat or raised patches. These can acquire one of 3 morphologies. Number 1, it can grow into large masses of 5 cm or more. Number 2, it can infiltrate diffusely. Number 3, it can ulcerate deeply. Microscopically, most frequently tumors produce mucin and form glands with intestinal morphology. Less frequently, tumors may be composed of infiltrative signet ring cells similar to diffuse gastric cancers. In rare cases, tumors acquire shape of small, poorly differentiated cells similar to small cell carcinoma of lung. One important histologic feature is there is a segment of Barrett's esophagus nearby.